Long years back, 19 years back, I was here on this stage getting married. And I love this venue. And today, when I came to this venue, the entrance, all the memories came back and it was really happy. It is happiness, and sometimes moments come again. Today, this is the first time ever in my life I'm presenting twice in the same venue, in the same conference. So I would like to thank the committee of the conference for inviting me again. And I would like to thank Dr. Meera and the Emirati Dermatology Society for giving me the trust to present in the session of Emirati Dermatology Society. My name is Meera AlAdawi. I am a dermatology consultant. I am working in Sheikh Khalifa Medical City. Today, I'll talk about the challenges and treatment options of atopic dermatitis, and I'll focus only on adult type due to the shortage of time, and we need to focus only on the challenges and treatment. So atopic dermatitis happens in adults 2 to 5% only. And the explanation of having atopic dermatitis in adults divided to 4 different explanations. It's either childhood atopic dermatitis that extended to adulthood, or childhood atopic dermatitis that cleared completely and then activated during adulthood. Third type is adult type atopic dermatitis, and this did not happen during childhood, only appeared during adulthood before 40s, and it's usually recalcitrant, severe, difficult to control, always before 40s. And the last type is the aging type of atopic dermatitis. I'm sorry, this does not work on the screen. Aging type of atopic dermatitis, it happens after 50s. Never happened before that. And it has different pathogenesis and explanation. So focusing on the adult type, atopic dermatitis, it happens before 40s, but it was never there at childhood. Always recalcitrant, resistant, can be palmar, hand dermatitis, or nummular dermatitis. And the last type, the aging type atopic dermatitis, can be generalized. And the explanation of the pathogenesis of this type is, first, the skin barrier defect. Second, is the immune system of elderly, that it is affected and activation of T helper 1 function along with the T helper 2 function, and they call it immunosenescence, and this disease sometimes called eruption of senescence. The third explanation is due to neurodegenerative disorders may lead to pruritus by either central or peripheral effect, and that was explained by Dr. Meera in her presentation. So those are the 3 explanations for elderly having atopic dermatitis. So why those patients never had atopic dermatitis during childhood? Is it because it was very mild? Or maybe the mother have lots of children and she cannot recall? Or is it because patient was living in a humid area, and then when he decided to go to university, he went to other continent or university where the factors, environmental factors, caused activation and aggravation of atopic dermatitis? Or is it because of pregnancy and multifactorial causes that cause atopic dermatitis during pregnancy for the first time ever in the life? So whenever you have a patient with atopic dermatitis presenting for the first time at adulthood, you need to ask yourself, is it atopic dermatitis or something else? There is this very long list of differential diagnoses. It can be one of the differential diagnoses of severe atopic dermatitis that presents at the first time during adulthood. Not only atopic dermatitis, it can be photodermatitis, it can be allergic contact dermatitis, it can be scabies. It can be due to drug side effect like calcium channel blockers. It can be nummular eczema, stasis dermatitis, dermatitis herpetiformis, and Dr. Raghda talked about that. Xerotic dermatitis, widespread seborrheic dermatitis. Also, bullous pemphigoid. There is the first stage of bullous pemphigoid, also known as prodromal phase. And this is exactly atopic dermatitis. It can last for long years before diagnosis bullous pemphigoid. And and then eczematic psoriasis. How many skin biopsy came to be psoriasiform dermatitis? And it's challenging for us to treat it. Is it psoriasis or eczema? Which biologic I have to select? And last, mycosis fungoides and Sézary disease. This is one of cutaneous T-cell lymphoma. The first stage of mycosis fungoides can be patch stage, which is exactly like atopic dermatitis. So you always need to have high suspicion for all the differential diagnoses. Look for it. So there is the most important clinical features of atopic dermatitis is location, morphology, and is it with atopy or not? Location. Adult type atopic dermatitis is recalcitrant, severe. It can be hand dermatitis. It can be periocular, and it's very challenging. It can be nipple, but be careful. This needs to be bilateral. If it is unilateral and resistant to treatment, you need to take skin biopsy to rule out Paget's disease. Excellent. And then the flexures, we need to check the antecubital fossa and popliteal fossa, and it's always there, very severe. The lesions morphology, it can look like localized lichenification, or it can be generalized lichenification. It can be excoriations. And it can be very severe excoriation dryness, but this is erythroderma secondary to atopic dermatitis that is really challenging for everybody to diagnose and see in skin type 5. So those are not the only challenges that we face with severe atopic dermatitis and its differential diagnosis. Also, patients can have more than one diagnosis at the same time. Patient can have atopic dermatitis plus contact dermatitis. So examine properly and be very suspicious. Is it contact dermatitis that we need to investigate with patch test or not? And then this is the bullous pemphigoid prodromal phase. It is atopic dermatitis for my eyes. Sometimes it's for long years, there is no blisters. So if you think that this patient might have bullous pemphigoid, take skin biopsy, not only for light microscopy, but also for immunofluorescence. And this is the only way to confirm the diagnosis. In this stage, the treatment of bullous pemphigoid is different than atopic dermatitis. Then dermatitis herpetiformis, Dr. Raghda explained it earlier. It is resistant, does not improve with topical treatments. It has different way of management. Of course, diagnosis, skin biopsy, light microscopy, and immunofluorescence. Both of them are needed. And it is secondary to gluten sensitivity. Mycosis fungoides patch stage is exactly like atopic dermatitis, especially if the patient says, oh, I had atopy at childhood, like, oh, khalas, you will really rule out mycosis fungoides. Then be very careful. Mycosis fungoides diagnosis is not only a single skin biopsy. Patient will need 3 different skin biopsies from different regions to diagnose. And even our dermatopathologist find it challenging to diagnose And even they send the biopsies sent out to other hospitals to confirm their diagnosis. When do you take a skin biopsy? Do you take skin biopsy for everybody? Of course not. Yeah, when it's suspicious. When else? When do you take a skin biopsy? If there is abnormal presentation, if the patient treated but not cleared, it's not satisfying for myself. So I need to diagnose. So if the patient is recalcitrant, if the improvement is not as what I expected, and if there is, for example, both atopic dermatitis and contact dermatitis, skin biopsy will not help me to differentiate. Patch test need to be added. So always remember this long list of differential diagnosis and raise the bar of differential diagnosis and suspicion. Some pitfalls that we always might have with our patients if there is family history of atopy and they mislead us. And if there is a skin biopsy of previously treated area, it is not remarkable. It's not adding any value. Is it atopic dermatitis or not? Maybe you need to wait for the disease to be active and repeat the skin biopsy if needed. So always make sure that it is not allergic contact dermatitis, it's not scabies, not bullous pemphigoid, and not mycosis fungoides. And make sure that patient is compliant. Always in the first visit with the patient, I educate the patient and I call it ABC eczema, and they laugh. And they're like, Alif ba ta. Today you need to learn. I need to tell them, how long is the shower? What soap to use? Is it okay to play with dust? And when is the best time to apply emollient? All of these are really important. When is it enough to have topical steroid and when to add antibiotics? When is it the time to add systemic treatments? Those are ABCs, and they are very important. If the patient did not understand, he will not cooperate and he will not improve. Always rule out that there is no photosensitivity, no other deficiencies like vitamin D deficiency, zinc deficiency. Those can present as atopic dermatitis. It's similar. The approach to treat the patient, first, before treating, we need to assess the severity, and we have lots of assessments, scores that helps us to diagnose atopic dermatitis. It's not only for the insurance purpose. We do it to know the severity, improvement, the control of the disease. Score add, EASI score, IGA score, the pruritus severity score, POEM score, and quality of life. And then educate the patient, start with topical treatments, and if needed, you will need to go through all algorithm of treating the patient. I will not bother you with the whole algorithm, but if the patient has secondary bacterial infection, whatever topical steroid you use, it will not control the disease. So first, either combine topical antibiotic and the steroid or systemic antibiotic together with the topical steroid if needed. And our goal of treating the patient is to control the disease. I'm not aim. Of course, I'd love to have my patients 100% controlled, of course. But if the improvement is 80%, this is excellent. So improvement, not necessary to have complete clearance. And of course, the most bothering thing is the pruritus. So if the patients have completely stopped the pruritus and he was able to sleep nicely, he will really thank you. And he will love the medication. He will be very compliant on that treatment. So topical treatment, combined therapy, occlusion, Sometimes you need to add phototherapy, systemic option of treatments. I love this slide. It summarizes all therapy. So there is topicals and there is systemic treatment. Topical, including basic treatment, emollient and moisturizers, steroid, low potent, medium potent, and high potency steroid, and then calcineurin inhibitors, tacrolimus and pimecrolimus, and then the PDE4 inhibitor, the crisaprol. Then the systemic treatment, they divided to biologics and non-biologics. The non-biologics always think, is it okay to have the phototherapy or not? Of course, before all of that, I need to know few informations about my patient. Lots of patients in this region of world, they think using topical emollient is a stigma, or topical moisturizers or treatment stigma, especially males. And they think that topicals are for ladies only. So if my patient have this mentality, I should not waste my time and write creams. Of course, ABCs are important. If he is convinced to use emollients and topicals, I'll be really happy. But if I send him home with plastic of topicals and he doesn't use it, I will not be really happy. Second, what's the insurance that the patient has? If he self-pay, he will not afford biologics, for example. Does he have enough time, like free time, to come 3 times a week for phototherapy? This is very important. Some patients, they don't have strong insurance, but they can afford phototherapy and they have the time, like, for example, housewife or someone who's working and can go after working hours to Dr. Ramuna clinic. I always send patients who cannot come to my clinic to Dr. Ramuna because she have evening service of phototherapy. Do you have that in Brazil? Fine. And then the systemic treatment, it's all immunosuppression. Systemic corticosteroid, cyclosporine, azathioprine, methotrexate, MMF. Long years back, we did not have biologics. We had only those options. I was a resident that year, and I'm always looking for Dr. Ramuna support and like giving me the confidence. It's okay to prescribe cyclosporine. It's okay to have corticosteroid, but we need to taper down. But it was scary for me. When should I do investigations? What baseline investigations? How often I should repeat the labs? Cyclosporine, oh, okay, cyclosporine is good. It can control atopic dermatitis, only less than 6 months. And then when I was independent and first severe atopic dermatitis adolescence that I had, I started the systemic steroid, not controlled. Topicals, I'm painting the patient with all topicals, she's not controlled. And then, okay, let's start cyclosporine. 6 months. She was happy, but it's already 6 months. The guideline says we should not go more beyond that. Okay, let's do it 1 year. And then after 1 year, what should I do? I agreed with the mother. Okay, let's do it 18 months. And then the patient disappeared from my clinic. She was always suffering and struggling with this pruritus, teenager. Then we had the dopilumab. Unfortunately, I did not have her that time. In my clinic. And I was thinking about her, and I need to see this patient. This is excellent option. It will control the atopic dermatitis. And I was thinking, then I had half day break, like administrative hours. So I thought I have nothing today. Let's go to Al-Wahda Mall. Of course, I went. It was the new extension that time. I went to the H&M and I decided to go for shopping. And then behind the clothes, I saw the mother of this patient that I'm thinking about. Seriously, you're here? Come. I have a new medication. Please bring your daughter. We need to start dopilumab. She came next day. Of course, I was very happy. And, you know, it's like takhatur. I'm thinking about her, and then she's in my face. She started dopilumab. Until now, She's on dupilumab, teleconsult. Hello, doctor, I'm fine. Just refill my medication. This is great. This is satisfying for us as physicians. And now we have the blessing of having biologics, dupilumab and tralokinumab. Dupilumab is IL-13 and 4, and the tralokinumab is IL-13. And of course, now we have the JAK inhibitors, and they call them the small molecules. This slide summarizes all the medications that is used for atopic dermatitis. Dupilumab and tralokinumab are already approved for atopic dermatitis. The third option is lebrikizumab, and it is still phase 3 ongoing. It targets IL-13. And the fourth one is nemolizumab, and this is a blocking IL-31. This is the medication that Dr. Muna was talking about. It is approved in Japan for pruritus, but it's still not approved for atopic dermatitis. So this is, I believe, I'm looking forward for this medication, and let's see what scenario we'll have in future. And then the JAK inhibitors, the baricitinib, upadacitinib, and aprocitinib, and they block, the first one blocks JAK1 and 2, the second and third one blocks JAK1. All of them are approved for atopic dermatitis. They are considered as immunosuppressive medications, and they have black box warning, but until now, my experience is good with those medications. Of course, you need to select your patients. You cannot select a patient who is elderly or having cardiovascular issues with this option. It is not good selection. And of course, every medication have its positive and negative side effects. That's why we always need to select the medication according to the patient that we have. Again, dupilumab, it blocks the IL-4 receptor alpha, so it blocks IL-4 and 13. The tralokinumab blocks IL-13. Both of them are already approved. Third option is lebrikizumab, still not approved. It blocks IL-13. It is phase 3 ongoing. And the fourth one is the nemolizumab that blocks IL-31, approved in Japan for pruritus. Still not approved for atopic dermatitis. It's phase 3 ongoing. That's all about my presentation. Thank you for listening.